Good afternoon, everybody, and assalamu alaikum, rahmatullahi wa barakatuhu. You are here with Fatima Mirza, Asna Khan, and Dr. Dana Valekos. Asna, do you have a few words? Okay, thank you. And we have confirmed that we are in session 4. So I was just looking at my messages, and people are still trying to get in right now. So maybe perhaps we'll give it a couple minutes. So people need to see on their left side, there will be, on the left side of the screen, there will be menu bars. And in the menu bars, you have the agenda. So if you look at the agenda, there are all the sessions, and one of the session will say live streaming or live session. And that's the one that people need to catch in. So let's hope that everybody is in the live session, and welcome again. You are in the 4th session and the last session for today for the 2nd National Mosque Patient-Centered Outcomes Research Conference. It's a 2-day symposium. We had the first conference in 2019. Today, we are celebrating the 2nd and the 2 years mark of carrying the Mosque-PCOR journey. Again, we are exploring. So the topic for the 2nd Mosque-PCOR conference is exploring patient-centeredness in faith communities. The word patient-centered outcomes research turned out to be a very loaded word. When we first started, it's called PCORI. Oh, PCORI, patient-centered outcomes research. No big deal. Nice ring to it. But we didn't think much about it. This was good around 3.5 years ago. Well, no, actually about over 4 years ago now. So starting that journey back then, we're now to recognize that just the word patient-centeredness transcends different thought processes and understandings. So we have been exploring that throughout this day, and we would continue to explore in the next couple of hours and see where this takes us. So this project was called Equipping Muslims with PCOR-based Action-Oriented Research Tools. I know some of you are actually joining us right now and may have missed the first sessions. We had quite a bit of details about what this project is, what PCORI is in those 2 sessions. The sessions are recorded. We will be streaming them later on in the future, and we will let you know. You can also go back and have it streamed on demand. You got to give me 1 second, though. Let me close the door. I was hearing my own echo from the different room, and it just bothered. I couldn't speak, sorry. Okay, back to you guys. This particular project is actually a collaboration of 3 different nonprofit community-based organizations: Pastors for PCOR, Worry-Free Community, and Initiative of Islam and Medicine. And so now we start without any further delay. I'm going to jump into the third session, to the third or the fourth session actually for today. The third session happened to be the dedications and the supplications and the du'as. So technically, yes, for CME it is the third session, but we're relaying it as four. So adopting a faith-based PCOR toolkit to maximize health outcomes in free clinics. That's the topic for today. And we're exploring this quite extensively and relaying out our strategies for the free clinics. And essentially what happened was this particular project, Equipping Muslims with PCOR-based action-oriented tools, this was an engagement project to disseminate the Mosque-PCOR toolkit. Now, as we were disseminating it, we ran into community needs that demanded free clinic pretty much right away. So as a community-based organization, it's a call for action and you do it. And wonderful partners being the Advocate Aurora Health Systems, or Advocate Christ, I want to say, going back to the ACO framework, that Aurora Christ Medical Center became an ACO, and now it's called the Advocate Aurora, which happened just within the last 18 months. But it is essentially still culturally speaking, it is still Christ Medical Hospital. And so they bring in this deep sense of community roots and community engagements and community programming with their work. And so we got fortunate enough to partner with the family practice residency team, and Dr. Dana Valikos is actually the director of osteopathic medicine with the family practice program there. So it's a delight to actually work with the whole team, and we will hear a lot more from her today. Okay, you guys are familiar with me. Many have seen it. If not, then you can go ahead and move down the link then. So I'll move on. Now, here's the question that we ask ourselves. Given the comprehensive scope of ACA legislation to tackle the iron triangle of healthcare, is there still a need for free clinics in our communities? Now, apologies for a loaded question there, but we have gone over quite a bit of ACA legislation and the wonderful things that it brought with it into the communities and into healthcare, and it's literally tackling every aspect of healthcare where there are disparities and inequities, and ACA is pushing to expedite health equity. That's the main push. No matter what sector or department you go to within ACA, the one goal they have all in common is to expedite health equity. So now, knowing that, why is there even a need for free clinic in our communities when ACA is supposed to handle everything? We should go just to ACA and we should simply say that, oh, here's ACA, let's pull it from the ACA's legislative body and roll it out. You will see why we're still in that, why we still need this. And I don't see this need going away for at least for the next 20 years. So let's examine what are some of the strengths and opportunities that free clinics environment or this particular question comes in. Free clinics are a trusted space where patients walk in without the fear of cost. They know it's a free clinic. They can simply come and ask. Whereas you won't be able to go to an environment where there is a fee structure and you say that, I don't know how much they're going to cost me. And just that fear keeps people at home. And therefore, they are unable to even seek care, let alone walking into a healthcare environment. So free clinics provide a safe haven for uninsured to explore their healthcare options. Again, people don't know what kind of healthcare they're going to get or what do they need. So that's a place for exploration. Several providers can partner to benefit patients, and that's again being in a free clinic environment. We all walk in without the fear of conflict of interest. We say that we're doing this because for the community, and we know that. What is in it for me? That really doesn't support this kind of environment because you're in it for the community need, and pretty much you are in the same you're seen and do things from the same intent, which is key to take things and move things forward. Now, low-cost options are available to free clinics, provide insight into the hidden resources. And now, there are a lot of free, not completely free, but low-cost options, for example, for diagnostics, for medications, labs. All of these places provide basic necessities to cover the uninsured healthcare costs at their own cost. So these resources are available to free clinics, and they provide insight into the fact that how low that cost could be, and what is the bubble that we are sitting on. And again, that bubble is not for any useless thing. It has its own economical power to carry things or move things forward. But yet there's a lot of room for cost adjustments. And free clinics would provide insights into those cost adjustment opportunities. And then again, essentially, all of these opportunities can help cultivate a culture of patient engagement while improving healthcare outcomes. It's not that you would, at one point, you would healthcare outcomes, and at the other point, you would do patient engagement, but free clinics provide both of these opportunities at the same time. Many of the engagement projects that we come across with, they may not have it's an engagement project, so it's not necessary for them to provide the benefit as a healthcare outcome measure, because healthcare outcome measures is another ballgame. Patient-centeredness is another ballgame, but free clinics are the spaces where they come together, both of these. Threats and weaknesses. So there are definitely, it comes with some threats and it comes with some weaknesses. It's very difficult to operate. I got to tell you that it does require somebody who's technically savvy, understand the healthcare, have the healthcare literacy, must also have the clinical information, clinical knowledge. Credentialing information is necessary, even though it's not used to set up a free clinic. But knowing that credentialing and contracting really puts things into place. Knowing how healthcare IT plays a big role in this. So it is a very daunting task for anybody to say that, oh yeah, well, I can actually go and see a patient in a free clinic. Yes, you can go see a patient in free clinic. However, you would not be able to generate outcome measures from that operation. And that's the reason why it can be cost prohibitive to set one up. So therefore, the conclusion is that free clinic can be instrumental in tackling health disparities across diverse population, given that you have the expertise or you partner in with the expertise. And that's where PCORI just clicks right in. So we talked about the iron triangle of healthcare. So exactly what is that? Because understanding this triangle is extremely necessary to tackle any health disparities in our communities. Because again, ACA legislation works through these channels in order to make an impact and in order to make this entire healthcare system better. So the iron triangle basically has three components: cost, quality, and access. In the middle of it sits health systems and partners. When you translate that into the ACA language, the cost is being catered by or being attacked by accountable care organizations. The quality is being attacked by Center for Medicare and Medicaid Innovation, CMMI Center. And the access is being attacked by the healthcare marketplace, also known as Obamacare. However, the entire ACO is also known as Obamacare, but when you talk to general public, they think that Obamacare is mainly that healthcare coverage piece through the marketplace channels. But actually, Obamacare is entire revamping of the healthcare system. So, and in the middle of it actually sits the translational sciences and the PCOR, and it's the PCORI Institute that has funded us to actually put this project together for the engagement, where we are disseminating a faith-based toolkit. We will hear all of that about it a little bit in today's, and tomorrow onwards we would hear everything about the toolkit. So ACA came in, and you remember George from this morning. George actually came to the United States in 2007 at his son's graduation. Remember that? And then now he was in Cook County. Now in 2013, he moved to Will County. And what happens when George moves to Will County? He lost his health coverage that he had with the county care. But to his rescue, ACA kicked in 2010. And George actually can... he actually can buy healthcare coverage. That's how ACA works with him. So think about George and think about the iron triangle as to how ACA is attacking all of the problems that George has and giving him with the solution. He can buy healthcare coverage. The available options that are there would be the ones that would matter to him. And we would know exactly what that means. Actually, we explored in depth what matters to him in our first session. But CMMI, the Center for Medicare and Medicaid Innovation, actually provides the innovative methods and innovative techniques for communities and for patients, where patients can apply that or go to a particular network or a hospital system or a research project where these options are available to them for their chronic care treatments. And that's what it would mean for George, that he would have better care available through research and development as well. All of his care will reside under the same network, under the accountable care organizations. George would not have to get out of the network and find him without coverage. Pretty much everything that he would need as a patient would reside under the same ACO. And that's why I first mentioned that Advocate Christ Medical became accountable care organization became a part of Advocate Aurora healthcare system, because Advocate Aurora actually is an accountable care organization. And not only do they have one hospital, they have many hospitals under their umbrella for Advocate Aurora Accountable Care Organization. And they are making sure that the entire population who they're serving has better health outcomes as the time goes by. And so the Center for Medicare and Medicaid Services and the AHRQ that we discussed this morning, they keep tabs on Advocate Aurora to actually when Advocate Aurora said that, they will be providing better care, are they really providing better care? What do their numbers say? And all of the care that George gets logged into the healthcare systems, and it becomes part of compliance. It becomes part of outcome measures. And so at the 30,000 square feet level, or in a nutshell, anybody can say, or when the healthcare epidemiologist and the healthcare researchers would look at these numbers, they can say that, this community is essentially doing better, or is it essentially doing worse? And we have a way to measure it now. So moving forward from that point on, what are some of the ACA's advantage for the free clinics? Right, that's what we're discussing. We're discussing that in the context of free clinics. Now, ACA, there are many features within ACA, as we talked about the accountable care organization. We talked about the health coverage marketplace. We talked about the CMMI, the Center for Medicare and Medicaid Innovations programs. All of that are there to lend a helping hand to free clinics. And you're going to say that, well, that's ACA. If you have ACA, you don't need a free clinic, right? Think about it. How would those services lend a helping hand to free clinics? That's exactly the piece that we're going to explore in this. And that disconnect is our strategy to have a free clinic out there. So think from George's perspective. What does George have? George's age. Is George eligible for healthcare coverage or not? Where does he live? The zip codes, George's healthcare conditions. All of those actually are variables where George can have several options for each of those variables to choose from. And that's the beauty of ACA. Let's keep moving. So let's look at these variables in depth as to what exactly George has as options. Now, let's examine the variables first, or the inequities or the determinants, social determinants first for George, and then we will go over the options for George. Okay. Going back to this Robert Wood Johnson Foundation's model of healthcare ranking, 70% of health inequities are impacted by health behaviors and social and economic factors. Where does the 70% come from? Right? That's the main question. Now, this is a model that many community health researchers have adopted. And it turned out back in 2014, when they first published it, that, wow, clinical care is only 20% of the that contributes towards the healthcare. Because when we have a healthcare condition, we think that, oh, you know what, I'm not feeling well, or there's something not right with me. Let me go to the doctor and see what that is. And we directly go to the doctor. The doctor is tasked with diagnosing and prescribing. That's what they do. That's what they have been trained to do. So they would look at you, they would say that, is there a diagnosis that exists? Is your body in shape, or it's working well or not? And do you really need a medication? They cannot diagnose if your water has lead in it. Eventually that will happen over the period of many, many months as they would go through diagnostics. They cannot diagnose if you are exposed to radiation right away. These are all environmental conditions that contributes 10% of it. The doctors would not know that if you don't have enough food to eat in your house, or the food that a person has in their house is so fatty that they're running into health issues with that. But all of this these are the health behaviors. These are the economic factors that are impacting our health. And we want the doctor to answer all of this. I think that's a little unfair. We need to look at other aspects, and because there are so many disciplines that handle all of these different economic factors and social aspects and health behaviors, that there is help available at all different levels. So we need to look at health, our own healthcare, our own well-being in a little different way, and think in those terms. So now, if you look at all of these different people that are out there, they're the healthcare stakeholders. They are patients, they are caregivers, people with lived experiences. People actually with lived experiences can provide insight into our own well-being. They are one of the most valuable piece of healthcare, piece of the puzzle of the healthcare, where they provide insight into the future, and they provide insight to the present as to how to handle such problems. And so there are a lot of lessons to be learned from them. The providers, there are different types of providers, and they're all looking into that, how to impact these social determinants of health. Dr. Rebecca actually just finished up a presentation about well-being and asset mapping sessions from this morning, and she talked about all of the different community assets that make up our social capital, or the social networks, the structures that are there to support the social factors of this. So it was a really nice session, and we had a lot of good dialogue in that session. It's also lived in online, and you can listen to it if you have missed on that session. But she talked about how all of these assets in the community, there could be a vitamin shop in your community. There could be a support structure at the faith-based community, where they may deal with some kind of, I'm not feeling too well today, or I can't sleep at night. What could be going wrong? And you go to the nearest faith-based community, or your local faith-based community, and you can seek help. So many resources that exist in the community, that all of these resources can actually help us out with our well-being. So it was a wealth of different ideas came out of that session. And then so another question comes out, that the question that we left that session was this: how do all of these resources can align themselves up to talk to each other, so that I, as a patient, or George as a patient, can go to the right resource and find the right help. And that's where the gap is. All exist in silos, and we're not all working together to give each other a helping hand. And therefore, PCORI comes in. And PCORI brought us these, PCORI is a methodology. We discussed quite a bit of detail in the first two sessions, so I'm not going to go over all of that. But PCORI gave us this gift of 5 principles to align community assets. And again, I got to tell you guys, these are magic principles. If there is something called magic that exists, I think it exists within us. It exists in our understanding, it exists in our cognition, and it exists in how we take words for granted. So these 4 or 5 principles, we take them as 5 principles, and I'll tell you why we take them as 5 principles. So reciprocal relationship, it's about decision-making, authority, and it should be collaborative, and it should be clearly defined. Whether it's at the patient level, patient-doctor level, whether it's at the community-based organizations level, whether it's at the leadership level, these understanding reciprocal relationships and how making the reciprocal relationship works is key to understanding, key to making these assets work. But once you start with that, then you come up with the process of co-learning, and you're learning from each other. The second thing is partnerships. So with partnerships, there has to be equal and equally shared decision making. So again, partnerships is a very tricky word, and everybody thinks that they are partnering, but they won't be partnering. They're actually adopting these principles in their thinking, in their strategy, in their tactics, in their operations, and in their behavior. So these need to be applied at all of the levels of leadership, all of the levels of management, and all of the levels at the grassroots. So the 4th principle is actually split of 2. Transparency is the first step of establishing trust, and honesty as the last step of establishing trust. By the way, through this project, equipping Mosque community with action-based research tools, we had 5 community health stakeholder meetings, and every meeting we explored one principle in detail, and we practically or showed with practical examples how each principle can be applied and adopted. The proceedings of these meetings and the recordings are actually available on our website and on the blog that Asna has diligently created. So going back to the principles, when you apply transparency and when you end up in honesty, what do you have? You have trust. Trust is not something that comes out that you actually work diligently towards. You work on transparency, or I work on transparency. I would work on honesty to build that trust. Trust is an end product. It's that outcome measures of patient-centeredness. That's what trust is. So let's explore this a little bit further. So with the engagement process that we have adopted from the patient-centered outcomes research methodology is it's a 5-step process. We start from introduction, and this 5-step process, I'll tell you, this one slide is worth, I want to say 10,000 hours. That's the value of the slide right here. And I'm calculating those hours because 3,000 are mine and the rest of them are my colleagues who actually diligently worked. And we through trial and error over the period of 1 year, we came up to this one slide. That's it. It's a nutshell. Introduction is actually the very first step of the engagement process. What happens here? When you first meet somebody, you exchange and you agree to accordingly, oh, let me have your number. Like, oh, give me your business card. Yeah, you keep it. You forgot where the business card was. They lost your card. What happened? The contact is lost. Nothing is happening. Talk about trust. We don't even have a contact there. And that's what happens at introduction. But what you can do to have effective introductions is exchange the contact information right away. Make that as part of your listserv. They become part of your directory. You become a part of their directory. See how mutually you are doing the same steps? You are equally and genuinely interested in each other, and that's the key to move on. That genuine interest. If there is nothing, if I don't want to know you, or I see you as a casual contact or casual introduction that somebody exists, there is no engagement. We won't be working together. In order for us to work together, in order for us to even begin to have a connection, I need to make you as a contact. So that contact really is the second step, and that's where you are exploring common interest. You're also exploring the risk factors and what do you both of you avoid, because that mutuality is extremely important to move on from that point. You are actually building a communications bridge. You are building opening communications channels, and so you are exploring the reciprocity in relationship. You're finding out what matters to each one of us. See how there is a mutuality, the two-way street that's going in the process of engagement, and that mutuality and the two-way street has to be open throughout this process. And that is why transparency becomes so important, but we will discuss that a little bit later. Then we move on to connection, and in the step of connection, co-learning is a key thing. And this is an active process, which means I learn about you, you learn about me. What do we learn about? We learn about our intents. Intent is crucial. I can't believe how intent is a self-reflective process. And again, it's a cognitive process. So unless I know what my intent is, I can never say what I'm going to reap. Whatever we intend that's what we reap. That's how it goes. Oh, I didn't intend that. Maybe I didn't know what I intended. That's how it goes. So it is very important for us to explore our own selves first, and what do we intend? What are our priorities? What are our goals? What are our values? What are our options and timelines? And that's when the partnership building begins. All of these is very detailed, but this is what happens when you engage patients, when you engage physicians, when you engage other leaders in the community, and it has to be mutual. One-way streets, you would go, but you're not coming back, or nothing is coming back from there. So if you decide that very early on, if it's not going to be mutual, you can say that, oh, this is not going to be this is not the road of engagement for them. And maybe you want to move on to another road or maybe you want to have other partners. So that would happen. In fact, Stephen Covey says that it would eventually happen if you have the right intent, and you have already put a process in place for other people to wean themselves out. So you're not really walking away from anybody, they are walking away from you. And that happens at the point of connection. So as soon as you start to co-learn, you think that, oh my God, this is too much. What am I getting in it? So from connection, then you move on to engagement. And at the time of engagement, that's when you are designing the opportunities, and that's where the partnership is starting. It's now you are putting partnership into action, actually, not beginning, but it's partnerships in action. And that's what engagement is. And once it happens, it's a beautiful piece. But if you have gotten to engagement and if you have not covered all of these pieces, I'll tell you this, that you're actually not on the road of transparency. The next step that would need to happen is that as soon as you built in transparency, the rest of these pieces are going to line themselves up. Because if you have perhaps missed connection, or you missed the contact and you haven't explored the goals and the values, and you are already at the piece of engagement, when you are building transparency which is the first step to build trust, the rest of these pieces are going to come together. And that's the beauty of this process. And at that point, you would understand that, oh, maybe perhaps this is not there. So basically, your partnership is not going to happen. Okay, that's fine. Let's see what we can do. And then you can go back and fix the little pieces that are there. So you can move on to a productive environment. And so as soon as you build that transparency, honesty comes in next. And it's a very automated process. And for trust, you don't even have to do anything. You can take it for granted that it's going to get there. I've seen it happen. So that's the background for the Be Well Free Clinic model. We take patient-centeredness as strengths and opportunities. By the way, this is our slide, which brings all of the stakeholders from different walks of life on the same page. There are healthcare administrator stakeholders who talks in SWOT analysis. Say that, you know what, is that a business case? What's the SWOT analysis? What are the strengths and what are my threats? I want to know about my threats because I'm concerned about my sustainability and I want to see viability. That's business talk purely. And you can move on to your outcomes research. You say that if you don't do that, that's the threat. So in business model, the top layer actually takes care of those business folks in healthcare. Your next one, you have the PCOR researchers. You got patient options. You got informed decisions. And that's what this model brings in. You got CBPR, the community-based participatory research. Now, these are the researchers that are already established in the community, and that's what they're working on. They're working with the communities, and yet they are not getting where they need to get with the ACA's goal for expediting health equity. This model will allow them to get there and brings them on the same page. So how do we in Worry Free Clinic adopt this model or put this model into action? That's the key. So Be Well Free Clinic is a faith-based community health, or Be Well Free Clinic. Actually, what we did was we designed a faith-based community health workers training program to align the different community assets so that everyone can talk the same language. And that's the unique edge that Be Well Free Clinic has to float this free clinic out. Without this community health workers talking the same language, the free clinics would not be able to provide the benefit or measure the healthcare outcomes that needs to happen. And how did we do that? So I'm going to quickly go over this because I don't want to, hang on just a second. Okay, don't know how that happened, but one of the tools we just went over, the 5 principles. It's one of the most valuable and useful tools that you can have in your toolbox for at any level of business. So these are the 8 core competencies that came from American Public Health Association. So we're not inventing anything new. We're simply using whatever that's out there and we are aligning. At Worry Free Community, we don't come up with best practices. We simply take the best practice and align one best practice after another best practice to create a model of best practices. So that's what we do. So these 8 core competencies, they come out, it's based on research. It's actually that's where the entire nation uses these core competencies. It involves community engagement and advocacy, system navigation, participatory research, or patient-centered research, public health concepts and approaches, integrations, coordination of services, education, social emotional support, and community cultural liaison. We took those and we added the Faith-Based PCOR Toolkit. This is the toolkit that was generated at the end of our first patient-centered outcomes research project. we came out with this toolkit in 2019. Actually, we went over that in the earlier sessions today, but we came out with this toolkit in 2019, and we used this toolkit to actually move to add that layer onto the core competencies of APHA. And it highlighted, so you see how, I'll give you a good example. So coordination of services and community engagement and advocacy. Now you can see that these are big and very broad terms, community engagement and advocacy. Knowing what goes into engagement now, you can see how loaded that word is. And so, you're adding community to it. That's another loaded word, because it comes with a cultural, linguistic, and its own practice baggage, basically. So you need another, in order to deal with a particular community, you need another set of best practices to add to the core competencies of community health workers, to tailor your community health worker model to support that particular community. Right? So that's what we adopted the Faith-Based PCOR Toolkit. This is a Mosque community patient center, Mosque community PCOR Toolkit that came out, and that previous project was led by Dr. Padela at Initiative of Initiative of Islam and Medicine. And he has been my mentor for the past several years, and that's part of the reason why I'm speaking the language today that I'm speaking. Thank you, Dr. Padela. And thank you, Dr. Johnson. We actually have, in this particular toolkit, it's also available online on the website and on PCORI's website, where people can take guidance from. There are mosque setup and best practices. There's program development strategies in there, and describes how to overlay PCOR project methodology over project management methodology for effective project delivery. Tomorrow morning, by the way, we have a session with PCOR leaders in mosque communities, and those are the leaders who have already applied these tools. So you can see how they have used this PCOR toolkit, just the PCOR toolkit and the PCOR methodology, and they've moved on in their communities to do community health work. So those would be additional support they can get as to how to use this toolkit. Moving on further and we added a layer of PCOR research and engagement tools. There are many tools on the PCORI website. Again, the 5 PCORI principles, PCORI methodology standards. There are 65 standards. I would highly encourage everybody else on this session to look into the PCORI methodology. All of this available is online. There's a research fundamentals course. It's a beautiful course that came out last year, I believe. And then you can become a PCORI ambassador. So you learn from the other people who are doing community health and engagement research. So the training program really combined all of this together, and we actually came up with a 24-hour classroom training session and 240 hours worth of community outreach and community engagement. And that after that, you are able to get yourself certified as a Mosque-PCOR Community Health Worker. And there is value in it, because people who you would also hear a couple people tomorrow that have been trained, and they actually are very pleased with the program. And it's less than a year that they have been trained. So what does this mean for George? We talked about this, that George has these 2 types of gaps, that these are the gaps that happen with his medications or clinical gaps, and he has these social gaps. And both of these gaps are being fulfilled by PCORI and by the translational sciences. Again, we went in depth, in detail about the translational sciences, and National Institute of Health has a methodology and for the translation. No, they don't have a methodology, by the way. The translational methodology is missing from healthcare today. And part of the reason why we are all struggling is there's not just going to be one translational methodology. We need several translational methodologies at many different stages of engagement and practical aspects of healthcare. So in the next 20 years, you would see that it would be coming out in our environment, and we would be adopting some of the practices that calling ourselves that, oh, we adopted a particular translational model. But I'm looking forward to that. Okay. So, Be Well Free Clinic becomes a natural fit for faith-based patient-centered outcomes research because now it has a component of faith-based, it has a cultural and linguistic component, it has the core competency component, and it has the research component to it. And so, all of this is when you come out in an environment which is known to be a trusted space. What does it give to George? Think about it. It's a beautiful feeling that when you're loaded with all of these assets and you're sitting there. And I tell you not, Tuesday mornings, in fact, I was hoping that somebody else would take this up and would do that. But when I walk into the clinic, I feel good about it. That, wow, I walk into that clinic with a confidence, knowing that no matter who walks into this clinic today or whatever kind of need they have, we have an answer for them. That is a feeling that is just, it's invaluable. I got to tell you that. And again, I thank Dr. Vallejo's team from the depths of my heart. And this thank and gratitude, I think, will go on for my generations, for many, many generations for them, because they have taken this first step to partner with us on something very unique and very valuable. And we are just, it's the trust in each one of us that we have that we're moving forward on. So with no further delays, I'm going to invite Dr. Vallejo's, and she's going to walk you through the actual clinic because it's their clinic. We're in there filling in the gaps, and we're there to help them. We're there to help George. So Dr. Vallejo's, how can I help you today?
Okay, so I feel like the complete opposite. I feel like it's your clinic and we are there just doing the medical part of it. Because as you said, that's only really 20% of what goes into people having good health outcomes. And so really what we're realizing, so I'll kind of explain just how this all started. So I'm one of the faculty members for the Christ Family Medicine residency. And we recognized for the last couple of years that we had a big gap in our training of family medicine residents, which was community medicine. They weren't getting a lot of experience outside of, the four walls of the hospital and our clinic, or, the subspecialty clinics where they rotate. And then this opportunity came up to partner with Worry Free. And so what we do basically is we see patients 1/2 day a week, and there's so much more that happens than just us seeing patients. But during that time that the patients are in the office, they get all these other services. So I'll kind of start from the beginning. So George calls our phone number that he saw on a flyer somewhere. Someone gave him the phone number knowing that he maybe wasn't happy with the healthcare he was receiving, or didn't have healthcare coverage at this time. So he calls to make an appointment, and he's connected with one of these awesome community health workers that have all these resources. And this community health worker simply, at first, not so simply, makes an appointment for George to be seen at our office. The electronic medical record that we use is Athena, which is one that's used by a lot of free clinics. So people might be familiar with that. So he has this appointment. So then on the day of the appointment, he comes from home, obviously, to the clinic, which is at this Alnada Community Center. And the clinic intake, he walks in and there's a table in front, and there are community health workers in the front, and they welcome George in. They take his information about his demographics. They also do an assessment of his social determinants of health, his health-related social needs. They talk to him about his place of work, where he lives, his language, where he's from, his residency status, lifestyle, faith, food, and which congregation he goes to. And all of that is then input into the Athena EMR. Then we have this extra kind of layer of bridge between the kind of social needs and faith needs and all these other needs that people have, and their healthcare needs, which is a faith community nurse that works with us. And she further, and I say she because we have one specifically that works with us that is a female, she takes a patient's vitals, asks them about their vaccines, their medical history, their health habits, risk factors, medications, and then really does, along with that, a health literacy assessment, and finds out if there are some services that she would be able to offer the patient. Again, this all goes through the EMR. And then the patient is seen by a physician. So the model that we have, because we are a residency training program, we always have a different resident. And we have about 14 residents that will be rotating through at any one time. So the resident is the first to see the patient, and then there's an attending, a supervising physician that's available that comes in after the resident has a plan that they've made with the patient. And so this physician, of course, addresses what clinical needs the patient is there for: high blood pressure, an injury to their shoulder, just catching up on health maintenance. But also, of course, because we are family medicine and we're looking at patients holistically, with every patient we see, whether it's in the free clinic in our office, we're taking into account social and well-being needs. Sometimes patients feel more comfortable telling a physician something than they do someone that is a lay person, and the other way around. Sometimes they're more comfortable talking to someone from their community that they identify with than they are talking to a physician. So those types of questions about their health and their environment are asked again by the physician. Mental health, of course, is always a part of an assessment that we do with the patient. And then something that is unfortunately a part of medicine is considering how economic factors that patients face can limit their follow-up, limit their ability to follow through on the plan that they've made basically with the physician, and trying to allay and to kind of head off some of those limitations. And throughout all of this, as I said, we're trying to look at the person, the individual holistically. So after our visit with the patient is done, as physicians, we then take the patient back to the community health workers, and they are connected with a health coverage counselor, where it's determined by all of the things that Fatima had mentioned before, if they qualify for any kind of healthcare coverage options. And then the community health worker has another encounter with the patient, again, based on what they may have identified at first, something that may have been identified during the visit with the physician or with the nurse, and they do this part that Fatima had mentioned before, and she said it in such a nice way, that it's not fair that the doctors have to be doing all of this. We agree. Also, that's not what we're trained to do. We do become good at it over time, I must say, because in a traditional medical practice, we don't have community health workers. We have maybe a social worker that takes care of patients that have one type of insurance, and they are stretched so very thin. And so we have to learn what resources are out there for our patients. And we are not good at that because we're busy doing the medicine part of medicine. And so this is, I think, something that is just so special about free clinics, that the community health workers are there and are available, and specifically this free clinic, because they know what's out there and they have connections for things. Fatima said originally that she walks into the clinic knowing that whatever patient walks in, whatever they need, we will be able to address it. And that, I think, is something that scares physicians from doing free clinic work, is you think, I don't know enough about what's out there. But anything that any of our patients have needed so far, whether it's a free blood pressure cuff or help with a food pantry or something like that, they've been able to get from the community health workers or the nurse. So that has been just invaluable. So then I think the next slide is just kind of an overview of how everything comes together, everything that Fatima has been talking about.
So let me actually put the whole thing into perspective, and thank you so much, Dr. Vallejos, for detailing out. And this is exactly what it just hit me as you were talking. In project management, there is a concept called resource loading, and what that does is it actually looks at every role of the project in the project, every role that for the project team, and they say who has most resources and who has most time. So the project manager's job is to take resources and map it against the time. And really, maybe today's healthcare challenge is actually resource loading. The assets are someplace, and we are asking somebody else to do that job. likewise, if this ask the social worker, they're inundated with the things then, and the amount of what they get paid for, or the number of hours that they spend on one case or two cases, and they can't support the rest of them. So the burden of work that's there, it needs to be shared, and it needs to be aligned with the amount of time and resources that are there in the healthcare environment. Free clinics are actually really a good experimental ground, I gotta say. Deep down there is a researcher in me. I'm sorry. I look at everything as an experiment. And I think, free clinics do provide that a space to experiment, and we're not experimenting on anybody's cost. Not even a patient is being, how in the research terms that why would I go to an experimental program? Am I a guinea pig? I would ask myself that. This is not something that we can even walk in and say that this is what it is. It's a very this is what I would call an adaptive trial in methodology terms. So the free clinic is where patient is walking in and they know that all of these are simply options for them. They can pick and choose whatever they need. And all we are doing is we are training there are all of these, you see how each person has become trained in their specific role. And because they are trained to that depths of understanding for that resources, they're able to talk to that patient in their language, in the terms that's what is different for them, what matters to them. So when they connect with that patient, not only they are connecting, they are engaging with the patient. Every step of the way, each person and each piece, because of the confidence that platform brings in aligning resources, it leverage that confidence to all of the team members, and you become sort of like links to each other, and you bank on each other, and you can translate each other's thought and then present it to the patient for the best of their vantage. It's a place where we are experimenting with the best models of healthcare. That's what's happening. And that's why outcome measures are so important, because the models, the way this model would work, it can go in many different ways. And we would take it to wherever, when we see better outcomes, that's where this model will go. So the community need would literally guide us, and community feedback and their responses and their outcome measures will guide the model to have something better as a best practice in the healthcare system, so all of us can move towards the well-being. I just could not let this opportunity go when it came to the table having a free clinic, because I saw the entire thing coming together. And so the community health workers are doing their job. The faith community nurse is a crucial component. I cannot emphasize anymore. They're as important as any other pieces here. And in fact, I got to introduce Sister Nancy Romanchek, who actually has a nonprofit organization called Mosque Community Nurses of Greater Chicagoland, MCNC, or Mosque Community Nurses of Chicagoland. She has practiced faith-based community medicine for decades, and she brings that approach to the table. And we apply that approach with our community health model, and that it just plugs right in. And so with family practice community or community family physicians and the health coverage counselors, we were able to literally bridge in all the gaps. And in fact, to the extent that we put them on the path of wellness and well-being, because we bring in these community assets. We bring in each of these icon, by the way, let me go back here. Each of this icon patient-centered partner providers, when these partner providers come to our website to become a community asset or to become a resource on our website, we ask them that, there are certain things that you need to abide by. And again, 5 principles are one of the basic things that they understand, and they may not understand, but at least they get to know, they're introduced. Whether or not they get engaged, it's their it's there. We're there for engagement. The HFS is actually, this is the CMMI model. This is the CMMI piece where the state-based social services are being integrated with the Center for Medicaid and Medicare and Medicaid Innovation. That's where this piece is coming from. And there are many aspects in that, many programs within that innovative center. And by the way, if you guys, if any one of you Google CMMI, you would get this yellow and gray color website, and you can explore all of these different models that are out there. There are hundreds of them. Some of them work and some of them don't work. So we can actually support the patient care needs when we train our community health workers into that. But it's a very technical piece, and we're not there yet. We're still in the infancy stage of this free clinic model, by the way. And then, of course, there are translational sciences projects, community projects, which happens with NIH and the translational centers that are out there across the nations. And there are about 60 of them. And then you have faith community patient-centered project like PCORI's. This project is a PCORI faith-based project. And Patient-Centered Outcomes Research Institute funded us to actually engage community partners and to develop or to disseminate this Mosque-PCOR toolkit that we developed in the previous project. We took the toolkit, we actually went a step ahead by integrating community health workers into this model, and this is what we get. So, again, it's been a beautiful journey. It's been exhausting, but very rewarding work with us. I really do want to leave a lot of room for dialogue in this session. But at this point, I would like to see if Brother Ghassan is there or not. If he is around, then I would like to have him say something about it. But let me tell you what this is. Brother Ghassan actually runs a nonprofit called Al Nahda. And so all of this model, there are 3 partners that you can see in this model. There is physician is the Advocate Aurora Christ Medical Center. Nancy is Mosque Community Nurses of Greater Chicagoland. The community health workers are Worry-Free Clinic. And then you have all of these community-based resources and these health sciences or the research component that's coming together. But all of this is happening in this space called Al Nahda Center. And that is a nonprofit organization. It's in Oak Lawn. Brother Ghassan is actually the executive director. Excuse me. I first met him back in 2015 when this place first opened. And he has been on many nonprofit boards, and finally he realized that there's a greater need in his community, which is Oak Lawn, Bridgeview community, to have something like this that could support the growing immigrant community members out there. So right now they have a very active Salva drive that's actually going to be happening tomorrow, and that's why I have it on there. They have several nonprofit programs, and I would let him talk to you about that. But I'll tell you, I want to speak to the spirit of this. Brother Ghassan actually mentioned, as we were engaging in the project for PCORI, he said, you know what, Sister Fatima, all of this is good. We need a clinic here. What can you do? We need a clinic today. We needed it yesterday, but if you can get it today, that's great. What can you do? I was like, excuse me, what did you just say? I couldn't recognize. I didn't accept my ears actually. So, and I said, this is a partner who is ready to engage. So I recognize that we have already covered the introduction, the contact, the connection, and he's ready to engage. And it happened like this, right? So again, somebody has said that luck is when opportunity meets preparation, right? So that's what this was. And he had explored the market for his communities for the past 4 years as well. And when COVID hit, it literally hit all of us in the face. And we realized, wow, there are so many gaps. How are we going to do it unless we partner with each other? So when we were engaging, this opportunity came up, and I knew that I have known that Christ Medical Hospital has also been looking for partners, and we have been talking for the past 4 years, and things weren't happening. And this is through Jackie Russo, which comes to us through Melissa McGuire and other partnerships and wonderful persons. So, anyways, without further delay, I would like to have Brother Ghassan say a few words, because it's Al-Nahda where we have the clinic, where all of these partners come together and we help out our beloved patients. So, Brother Ghassan, I want to give this to you now.
Assalamu alaikum, everyone.
Alaikum assalam.
Assalamu rahmatullah. Yes, it's really motivated going through all this hard work to help the community. Al-Nahda Center been established back in 2015, and we start with about one line or two lines of prayer. Right now we have 3 Jummah prayers, with about almost 1,500 people coming every Friday attending the prayers. And we are here basically to serve, educate, and empower our community. So another center established for that purpose, and we have different programs, of course, to educate our community, between counseling, between school, educating our children.
Oh, Brother Ghassan, we can't hear you. Can people hear me?
Yeah, we can hear you. I think
Brother
Ghassan,
yeah,
Brother
maybe
Ghassan experiencing some technical difficulties on his end.
can you guys hear me?
Yeah, we can hear you.
Okay, good. So let me fill in some. So, but while Brother Ghassan comes out, let me actually move on a little bit. So the need of our time is to cultivate a community that is ready for outcomes research. So I want to make sure that we understand what this means. And Asna, please let me know whenever Brother Ghassan comes up, and I'll shut up, okay, and we'll have him finish his work.
He's here. I see him.
Okay.
Yes, Sister Fatima, you hear me? Everyone hear me?
Yes, we can hear you now.
All right. I'm sorry about this. I don't know why we got cut off. So we have different programs designed to put the community together, educating and empowering our community. So one of the programs is Salwa program, which is basically a food pantry, where we get introduced to tens of families that living in the area, diverse area, where we have African Americans, we have Spanish, we have Arabs, we have white people, we have different diverse community coming together, and they really need the service for family. For the food pantry. But when we sat down, we make the interview on one by one, we find out they really need also healthcare. They need other educations. We need to find jobs for them. So it's a very this program introduced us to a variety of things that the community in need. So also we have the family awareness program, which is every month a family come together, the children, the wife, the husband. We have a breakfast together, and also we discuss issues that also relate to the family that living around the area between Worth, Cologne, Chicago Ridge, Palos Hills, Bridgeview area. All this they come together. We have almost 70, 80 people comes on a Sunday morning around 11 o'clock to discuss issues that relate to these things. And one of those issues, of course, is the healthcare. And some people don't have the health card, they don't have the insurance. So these are very much needed in the community. And also we have the educational program where we teach our children, as I said, different aspects of the Quran and Islamic language and all this stuff. So it also helps the community to interact with their culture, keep going. And also we have the convert program, which is basically coming together with other faith organizations, sit down together, try to help each other, also do projects together. And also if somebody interested to know more about Islam or things like this, we discuss these issues. Of course, when the pandemic hit, the COVID-19 hit, it's really got us on a surprise. We were not really prepared. Now we have other communication we have to do. We cannot get too many people inside the center. We have to go through, phone calls, social media, all this stuff. It really, it hurt us a lot. So if we have a health system that is already there intact, I think it will make things much easier for us. So the COVID-19 delay us a little bit, but months down the road, we figure out which other way have to do to keep contacting our community. So then after that, we have we get the most important thing that we are facing, as I said, the social distance, the people. We used to talk to people one-on-one. Now we have to talk to them over the phone, and which is a little bit really hard to sometimes today to understand people or to feel or to have the same feelings when they talk. But when we have one-on-one, it'll be much easier. You get give more time. Maybe their family come with them. So all this stuff is really now is our biggest things that we're trying to get back together. Gradually, we're going back together right now. We're doing, you could say, 60% now going back as before, one-on-one and talking to people and doing all this stuff. So then of course, another center main focus is the human beings. If we have a human who is healthy, who is aware of what he's doing, he have his own job, he have his food on the table, I think we could make that person be an active member of the community. So all these things was in our focus as a Nahda Center start, that the human have to be complete together. If you have a food on the table, have education, and also have his health together, figure out if he needs assistant, if he needs to see a doctor, if he needs to see a nurse, it should be there. Basically,
hang on.
Yes.
Hang on, Brother Ghassan, just what you just said. So can you explain what the word al-Nahda means?
Al-Nahda means revival, which is basically renaissance. Renaissance, basically, it's a community there, people out there, and basically they have a lot of things on their shoulders, and they cannot keep up with their own lives. So we come here to see what they are troubled with. So reviving people, putting people to up to their level of life. So if they are short of food, they have low income, if they have a problem with their health, education-wise, jobs. So basically reviving people and put them into actions.
Yeah. So the reason why I asked is because this is interesting, because I had not known what that word meant. However, I have seen some of the actions that happened at Al-Nahda, some of the programs and some of the activities there. So I have known about that. And I was like, this is very interesting what they do. And again, all of that was coming out of their intents. Remember, talked about having intent and values. So when you have the right intent, it reflects and dynamically transcends itself into activities or into your behavior. And if you run a nonprofit, then it would transcend itself into those community programs. So having the right intent is extremely important. So it has started with the word al-Nahda and reviving that immigrant communities. That's the intent there. It fits right in with the well-being concept, with the worry-free community concept. So exploring these values and exploring these basic intents and what helps people spring from their seat. That's what we are exploring. And when you say that, wow, this excites me and this excites you, we have a shared common value. And when you have a shared common value, you can move on to an engagement program. And please go on. And that's how things happen. That's the magic in engagement. So go ahead.
Yes, 100%. When we talked initially about the health program and the clinic, and I see that people now interacting with this important project, I could tell that we are going on the right track. I mean, every Friday people come to me and ask me questions about the clinic and could you do this, could you do that? Then I think we were missing this important project in our agenda or our different programs. So I'm glad this is a workout. I'm glad we are in a community that it's in need, and I think the project will grow up to be one of the most important projects and Nahda is serving the community about.
Inshallah.
That's about it almost. Unless there's any questions I could answer, inshallah.
That was the picture that was taken at the inauguration, at the grand opening of the Be Well Free Clinic. We had many distinguished members there. In fact, literally every single person on this picture actually represent the many different stakeholders, community stakeholders, from the Melissa McGuire. Actually, this is Dr. Ghafoor. He brings the component of healthcare, community-based organization. This is our future right there. He's our volunteer, Hamada. Melissa McGuire she's the executive director of IAFCC. You see me recognized there. Here is the mayor of the mayor of Oaklawn, the mayor of Worth. The gentleman right here beside me is the mayor of Oaklawn. Right beside him is Congresswoman Marie Newman. Beside them, actually, right in the middle is the patient. She's my mom, by the way, and of course, happen to have health challenges at her age, as many of us do. It's wonderful to have her and to have her guide me and guide my insight and my thought is really extremely important for me to see whether I'm going right or not. She asked her, so I was saying that, no, I won't be available for next 3 days. So she said, well, what are you doing? I said, well, we are doing this symposium. And she said, okay, so what is it about? And I looked at her blank and I said, how can I explain patient-centeredness to her? And I said, we're just exploring what would make things work for you. That's all I said. And that's it brings home the point that that's what needs to matter. Next to her is actually the mayor of Worth, and right beside her is Nancy Romanchek. And then we have Javeria, who is our community health worker participant. She's a medical doctor, but she has participated in this project. Over right here is actually Uruj Rahman. She's one of the volunteers and the board member of Worry Free Community. And then next to her is another community health, not community health. He's one of the founding members of CHWs. Sorry, Brother Hassan, don't tell him I forgot his name. And then we have the three, all of these people that you see back in there, they are part of the community-based organization, and every single person here is a board member or a founder of a community-based organization. You see Brother Hassan right there. Here's our right in the middle, our technical guy, Masood Iqbal, who has made this show possible today. And right here in the middle is Dr. Smith. Hats off to her. She was the one who said, yes, we're going to help you. And she brought the team, and she brought Dr. Valekos. I'm sure Dr. Valekos and Dr. Ohara and Dr. Smith, they literally, I don't see a difference. They work together as a team. And whenever I spoke to one of them, I know the other one would echo the same sentiments because they're all on the same page with respect to community health. Right after him is Munib Ansari, who's actually the project manager for the free clinic. And then we have another our partner here, Moina. Both of Uruj and Moina, both of these are gurus in health coverage. And then we have another Al-Nahda board member, and Shadin Mali. She's also from policy. She works with Congresswoman Mary Newman. And then here we have Rashina Hussain. She's one of another community member stakeholders with the payer industry. And we have another board member here. So literally every single person here who came to this socially distant event happened to be either the founder, co-founder of a nonprofit, or work in the policy or healthcare sector. So we have a diverse group of stakeholders that literally came on the same platform. So we are very proud of this collective effort that came out. And I really do see that this is a new beginning for the PCOR projects, inshallah. So with this, I'm gonna give the floor to the audience. Well, thank you, Dr. Fadela. No, I really owe a lot of this. Really, I'm banking on many people and learning every single day from many people, and many of whom I interact. And it's just been a beautiful journey. Any questions, comments? You can put your questions in the chat, and that's how we would we can take your questions from there. By the way, so this particular model that we have, the worry-free community free clinic model, or the patient-centered free clinic model, mind that we're not going to patient-centered outcomes free clinic model. Right now, we only have a patient-centered free clinic model. We're making this distinction deliberately because once we engage the patients, that we're doing all the work together at the same time. It's not that we are not doing it, but that outcomes research piece or outcomes measures is a completely different class. And it's a completely different discipline. It's a completely different body of knowledge. So in order for us to get there, first, what we need to do is understand the variables that we have in today's healthcare system. And you cannot say that, oh, ACA, that was something in the ACA, or ACA did this or did. We got to understand how we interact with ACA. It's a living piece of legislation. It's a living piece of business, and it's a living piece of our standard operating procedures. So we have to come to terms with it and look into it, learn from it, and then move forward and align our objectives with the ACA's legislation to get where we need to go. Oh, on that note, I got to say that we have tomorrow afternoon. In the morning, we have a session with the PCORI leaders in mosque communities. And then we have Dr. Padela, who's going to explain in depth about what the Mosque-PCOR Toolkit entails. And right after that, it'll take us into a dialogue with the PCOR program officer, who will discuss with us the PCOR national priorities. There are 5 national priorities, and we will discuss that in detail with her as to how can we take those national priorities and incorporate them with our community-based programming. With how do we take PCOR priorities? And how do I integrate them in the free clinic model? That's what I want to know for tomorrow. So I would recommend that each one of you joining that session for tomorrow, and coming in with your own question, as if that's the PCOR. By the way, we've also shared that document with many people, and we are going to also put that. Asna, can you put that document, or Masood, can you put that document in the menu or in the social platform in the documents, where people have access to it and they can read through it. So when we come to the session, we come prepared.
Yes, definitely. We'll do that.
Thank you very much. Guys, I can talk forever, so I want to hear from other people. Give me some. Oh, there are some. Any questions? Dr. Valekos, while I have you and I have your undivided attention, that doesn't happen very often. You guys do so much. What are some of the opportunities that you see that we can provide? And I want to know from the clinical end, what are your challenges?
I had muted myself because there was a lot going on behind me. In terms of what has come up since we've started the Be Well Clinic?
No, in terms of your work and in terms of when you serve the community, what do you see? Where do you think the needs are, and in general?
Yeah, so in terms of kind of what happens outside of the office, one thing that we talk to patients about a lot that never really goes anywhere is having a safe place to exercise, to get some kind of physical activity. And that especially was limited with COVID because, you know, people were not exercising indoors. They didn't want to go to community centers, things like that. So having resources, groups, exercise classes, things like that to talk to people about, or to just be a space for people to get safe physical activity in is definitely one thing that comes up all the time.
And are they specific groups? Maybe like women ask you, or young girls, or maybe there are kids. What kind of sector is asking you these?
A lot. So kids for sure.
Okay.
And it's not the kids. It's us telling the parents, you know, we really need them to get more activity, and then them saying, well, we don't have anywhere for them to get activity. So there's that, especially with, you know, schools having been virtual. Sometimes the only exercise or physical activity kids were getting was, you know, PE class, and that was not happening. So that it kind of goes across all age groups. You know, I think the people that least mention it are kind of like the millennial age group, the age group after. I think because that group is so used to doing things virtually that, you know, when I say exercise classes, you know, they're like, oh yeah, I watch stuff on YouTube, or I have an app that does that. So, you know, people that feel like they would want the more in-person connected type of access to physical activity, or what am I trying to say? I guess like, yeah, doing it socially. That's hard to find for people.
Yeah, it kind of is in silos, and it's hard to get them connected. And I can imagine what used to happen to people who start to work, then they kind of lose the connection with the friends, and because you're so absorbed with that. But it's actually happening with kids now.
Right. And people are just more isolated in general, you know, and afraid to do the things that they were doing before, you know, formal exercise classes, things like that. So a lot of what we talk about is, you know, especially with winter coming, talking about going to the mall. You know, the mall is open early in the morning to walk before it gets really crowded. Exercising outside, even if it's a little bit chilly, you know, until it's icy, doing that kind of thing. But I think that's a challenge for us. Sometimes food insecurity had been in the past something that we were trying to deal with. And we have a food pantry in our clinic now. So that's not as much of an issue because we at least have somewhere to refer patients to.
Oh, that's good. That's good. Yeah, that's always been a challenge. But Asna had just put it in the chat that PCORI's National Priorities for Health 2021 is now posted on the tab. And in fact, these national priorities, the way PCORI works, as far as I have known, it incepted back in 2010 with the ACA, with the Affordable Care Act. And since then, so it had a 10-year plan, and it got reinstated again at the end of 2020. So it's reinstated for another 10 years. And so that means, that's reinstated for 10 years. So basically, in order to touch PCORI or take it out of what it's doing, you got to touch ACA. So it's so intertwined together that you can't do one without the other. So people like me who actually look at it and say, okay, fine, I'm actually planning my next 10 years out because of what has been put into the law. So these national priorities are there, and they would actually put funding behind it. They would put processes behind it. They would put resources behind it, methods behind it. So it is going to be a very exciting time to see how they would come out and would come out with different programs. And in fact, our healthcare would actually move into another direction. And right now we have a lot of opportunities where we can actually take these kind of community needs and turn them into projects that would support the community needs in the future. So if we get collected on the same priorities, which means that we as community say that, you know what, I need to have a gym in my community to support these kind of healthcare needs, that actually supports to the decrease in hypertension or better outcomes for diabetes or obesity. Then these are the projects that the government at the government levels that is being funded. And so once we align ourselves up with these priorities, funding becomes easy. Research outcomes becomes easy. But in order to do that, we all have to be on the same page. And what you brought out with exercise, I think that's really coming up as a need, big time. What else do you see? I have what impact has the clinic made for the residents so far? Oh, so you're talking about impact, measuring impact. We're not there yet, as I said. We're stuck on the patient-centeredness right now. So, and I do see that, once all of these variables have come together, we are going to measure, we would be measuring the impact, but we actually sense the impact though. So normally this is what I came to understand. When Mosque community, when we do programming in the afternoon and over the weekends, specific weekends, and right after Jummah, it actually works very well in our community. You get larger crowd. You do it any other times, nobody shows up. When we first started the clinic, I wanted to start it as in the afternoons only, and I said that's all weekend. That's when the community members are going to come in. But unfortunately, the physicians, time-wise, the need is that they actually they are more available in the mornings and not in the afternoons. And I said, okay, so be it. I think who am I to suggest what the community does? I don't know what the community does because I haven't measured their intentions as to how willing are they to change their behaviors. So I shut my mouth. I was like, I'm just gonna wait and see. So the first time it happened, the clinic happens in the morning. We had maybe 1 or 2 patients, and I'm like, this is not going to work out in the morning. The second time, no, I don't think the morning clinics are going to work out. The third time, maybe. And now, after about 8 weeks, we actually have equal amount of patients in the afternoon and in the morning sessions. And we have our first patient getting ready to go at 8:30. I'm like, wait a second here. We're not ready for you. We're getting here. So, you just never know what impact you can have unless you go in with that patient-centered approach. You are willing to experiment, you are willing to explore, and then you're going to be patient to see what impact you make. And then be ready to measure that impact, because measuring impact is not easy. And those are the methodology people. That's not me. So when things like that, I would pull in our methodologist experts, and they're going to guide us through that process, inshallah. But yes, I do think that the impact has been generated, and I think the credit goes to all of us, from the physicians to the staff to Brother Ghassan, who's actually made announcements. And in fact, as the word of mouth takes time. So as the word of mouth travels farther and farther, you would see higher and higher, bigger and bigger impact. I would think that we are still not at a critical mass where we can call ourselves that, oh, this is a completely a fully functional clinic yet, but we are getting there faster than I expected, actually. So lots of sprints coming up for us, but it's a good journey. Enjoy it. Anything else, Dr. Vallejos, that comes to your mind? Brother Ghassan, any thoughts from you? Oh, I don't see him around. Oh, I
think he may have left us.
Or he was probably at the backstage, something like that, if possible. If he's around, then Masood can pull him in. Any other thoughts, guys?
Oh, Masood had said what he was looking for the impact on resident doctors. Yeah, so I think, again, it's hard to tell because it's been such a short period. The kind of feedback I've gotten so far is, hey, this is fun. Like, community medicine is fun. I think that in general with residents, they like something that's a little bit different than their day-to-day, and community medicine is a little bit of a different kind of challenge. It's not, put in the order, send the medication to the pharmacy, and the patient will get it, and then follow up in 3 months. You have to use kind of a different part of your brain, a different part of your skill set. So far, I think that it has been really eye-opening for some of the residents, like the things that just happen for us so automatically in the healthcare system are not automatic, when you're taking care of a patient in a community clinic. So from what I've heard so far, they've been enjoying it. I think that they see the value in it, and they are interested to find out, more about how the community health workers work with patients and what they offer. So yeah, it'll be interesting I think that that's another kind of set of data and outcomes that we'll have to collect. I was just going to say that. Yeah, we're always thinking like scholarly work. This is great. We can measure this.
Yes. I was just going to say that, let's actually put a survey together before they even begin and what they know or what their expectations are. And perhaps we would do the similar surveys and this is between Dr. Patel and Dr. Johnson. They are on it. This is what you need to do. How are you going to know that if this has worked? But
exactly. Yeah. So yeah, that is something we've thought about. We're like, wow, we have to quantify this. There's something there for us to quantify. But yeah, so far the feedback has been great. They're excited to go back. They're interested in it. So. I'm not sure if there's going to be any other questions, but I do have to hop off. There was one. I got to head out for a patient thing. But,
okay.
Thank you so much for having me.
Thank you. Thank you very much.
Yeah.
Thank you very much for being a part of this journey with us. And I'm looking forward to doing wonderful things with you guys.
Yes, so are we. This is just so exciting.
Thank you for joining us, Dr. Blakos.
Thanks, Asna. Have a good rest of the session.
Thank you. We have
Thank
some.
you.
We have some. We have a few more minutes. If I could answer anybody's questions, I can. Otherwise, I will. I can actually. I wanted to see if I could go to the priorities document and give me 1 second, because I think I can pull up so that people are ready for the session tomorrow. And this is a great segue, because and a great point to or a great time to think about what we would be doing with the national health priorities. So let me put that right here. So that's PCORI's national health priorities. And there are 5 of them. So they were in a proposed period up until August 31st. And the proposed period, that was actually what was it called? It's called comment period, not proposed. The proposed priorities, and they were in the comment period. So they took public comments from many people as to how, because public has to provide the input. So every legislation that goes in, there is this comment period for public, but you have to catch it within that comment period within 60 days. And so you have to be in tune with, if you are following something and the comment period opens, you go in and provide your input. And this is the way you at a grassroots level, or I at a grassroots level, can participate in what shapes my future and what shapes my kids' future. So they just got done with their comment period, and now they are back on the table to modify these or to fine tune it according to the suggestions that they have received. But more or less, these are broad categories, and I believe it is not much going to change as far as the priorities is concerned. My feeling is that what will change is how they do it. That's one of the things it would change. But they came up with these priorities because they have measured the need of the time. Where are they? They have measured the gaps. They have read and measured the impact of community-based participatory research, and they have looked at the systematic research results, and they have done a lot of background work already in order to come up with these priorities. That's what I'm saying. So this is pretty much the way we would be going for the next 10 years. But these 5 priorities, let's take a look as to exactly what they are, and then I just want to make sure that there is no further question in the chat. Okay, so the number 1 priority is actually increase evidence for existing intervention and emerging innovations in health. So they want to increase the evidence that for the existing interventions. And existing interventions, you probably know these are the practices and the paradigms that already exist. And so why do they need to increase that evidence? To put that trust back into the healthcare and to involve all of the different types of different communities that can benefit from a particular intervention. And there are hundreds of thousands of interventions in medical sciences that that are there to be adopted, and also they are making their way into adoption, which meaning that there was again, valve transplants. There's details. There are all types of different valve transplants that's happening. And there's a tricuspid valve transplant that came in just about a few, not too long ago, and it's still going through the phase 3 clinical trials. Likewise, there are other, from grafting to, these are all medical sciences, but on the prevention end, there are several. Take COVID, for example, whether Johnson & Johnson is going to make a comeback or not. I actually prefer Johnson & Johnson for many reasons. And that's my personal thing. Number one, it's a recombinant DNA technology. So I would want to go with that as opposed to the messenger RNA technology. So, it's my personal preference. And likewise, whether that works for my particular population or other populations, we don't know that yet. So, those are some of the things which is needed. And so PCORI wants to put their resources behind these kind of interventions that can exist and increasing evidence for all the different populations that exist across the nation. So that is one of the key things. And what do they need? They need to connect people from the grassroots support with these researchers in order to do that. And without this kind of work that we are doing today, it won't be possible. The second priority is enhancing infrastructure to accelerate patient-centered outcomes research. So what does it mean when they talk about enhancing infrastructure to accelerate? The infrastructure that, if you go on the PCORI's website, there is a lot of resources that they have. And patient-centered outcomes research methodology is only 10 years old. The methodology book that came out, I believe that standards manual has a date of either 2012. I'm thinking it was probably 2011 or 2012. So it came out 1 year or 2 years later than from the inception of PCOR. So that methodology is being adopted by many people. The very first thing they talk about is the patient-centered. There are 4 standards in patient-centered methodologies, and they actually have have the 4 patient-centered standards, and there needs to be infrastructure for that. We don't have COVID actually challenged the infrastructure that exists today for connection. We don't have infrastructure to connect things at the grassroots level. All of these community assets still exist in silos. We don't know who exists where. Even, for example, just simple as that, if I go drive, for 10 hours in one particular direction, and I want to find out whether I can have halal food or not, there's not much resources or healthy food that pertains to my health. There aren't very many resources who would guide me at that point in time. Yeah, I can find a halal restaurant. It would have a halal logo, but I don't know what kind of food they sell. There is no infrastructure for us to guide us through that. The technologies that with Google and Yelp and all of these, the social medias, they're coming up, but it's all at a very, very superficial level. They are all simply introducing themselves right now. We have just started to connect with them. We're not even there with in terms of interaction. They don't satisfy any of our needs. So we have a lot of, and that's just with the social media, let alone a patient-centered infrastructure. So that really needs to be built. We don't even collect data points such as, how many hours of sleep does a patient has? That data points is not collected. How many calories, the food diaries that exist, and many people actually keep track of it on their own purposes. There is no infrastructure in place for patients to report on that. So see how that infrastructure needs to be enhanced, and all of that really needs to be in place before we start performing patient-centered outcomes research at an effective level. Advancing the science of dissemination and implementation. I just want to check if there are any. Please guide me if there is any. If there would be any questions, just interrupt. So the third priority is advance the science of dissemination, implementation, and health communication. Again, like what I just said, that health communication, we're having gaps with communication itself. Wi-Fi's are not even stable. So when it talk about technology, yeah, we can do a lot more things. We can have, Amazon deliver to us in 8 hours for through the Prime delivery. But it's all of those are really some of our choices, and yet we cannot engage people online. We cannot enhance trust online. So all of that infrastructure needs to happen. For that infrastructure to exist that penetrates in our culture, technology will not do it. We have to do it. The science of dissemination, for example, the Mosque-PCOR Toolkit Dr. Padilla would talk about tomorrow afternoon. There's a lot of depth in that toolkit. We talk about how to communicate. When you communicate, what are you looking for? How do you assess the barriers in the thought of a patient so that you can take that patient from their existing position and help them towards well-being? That needs to happen, and that's only going to happen through dissemination. And it's a science, because you can repeat it. These 5 PCOR principles, they are science principles, because if I use it, you use it, both of us are going to get the same results. And it doesn't matter in what time frames you use it, with what variables you use it. If we use it exactly the same way, you're going to get exactly the same results. And that's what science is all about, right? And the implementation of these methods and principles and the interventions. And all of this we really need to have to achieve health equity. Now, achieving health equity is a goal in itself. It's a priority in itself. And there are other priorities and other objectives and the goals that are missing from the other 4 items that would go into achieving health equity. So when we talk about achieving health equity, we are looking at a ground floor opportunity to say that, you know what, I don't care what exists out there. I want to see, how do we do this, and what exists before, what has gone wrong, and what can we bank on to move forward. So therefore, achieving health equity is a goal in itself, even though all of these other goals are driving towards health equity. But there may be many other priorities or many other objectives that are being overshadowed that we may not know. So that having that goal in place or having that priority in place actually opens door up for more opportunities, for more exploration into other objectives and possibly other venues which nobody has thought of as yet. So, I like that. It's a very simple 3-word priority, but it's just beautiful and it's loaded. Accelerate progress towards integrated learning system. And this literally challenge every single healthcare IT project manager out there. It's going to be a very beautiful thing, just even to embark on a project which would be a learning health systems project. And in fact, it talks about a lot of the AIs that can go in. So the health systems that we have today, they are primarily ACOs and accountable care organizations. We're primarily collecting data. We're not asking that health system to do anything. When we want the data, it is on demand. And an integrated learning health system is something that actually takes the data feed from many different sources and uses artificial intelligence to project an outcome and to project a trajectory towards a healthy system. And that's what an integrated learning health system is. These are basic. We're at a conceptual level of defining these terms and where it needs to go. Just that priority alone will remain a priority for the next 50 years. And I think I would be surprised if we actually, if we can make progress in my lifetime towards any outcomes that we can measure for that particular priority. So So I'm excited about the next era that we are embarking on. And in fact, I'm excited about the next 2 years that we are going to be embarking on. Thank you. Thank you, guys. So with that, I would want to conclude at this point. Dr. Padilla, we have a few minutes. No, it won't be possible through this. I tend to think we are in a room full of people, and you can ask anybody to speak at any time, but unfortunately, we have all of these links that we have to follow. So I know it's not going to be happen, but I thank everybody joining us in the call, and I want to conclude today's session with, and today, in fact, the day itself, may Allah subhanahu wa ta'ala help us and guide us in tomorrow's events, and help us to bring the wisdom and the hikmah that we need to understand these things, and may Allah subhanahu wa ta'ala guide us to go through the fruit bearing process, and to get to actually fulfill something which comes out of tomorrow's sessions. And inshallah, we embark on the next 2 years journey from that point on, and we would see each other on September. I do have this, so save the date, and we have tentatively put out inshallah. Allah can only make this happen. On September 15th and 16th of 2023, we will have our third Mosque-PCOR conference. It may or may not be me. It may or may not be Worry-Free Community, but the Mosque-PCOR conference, inshallah, will happen. And it may be other community members who would join and would carry on the burden and by sharing the leverage that they have with each other. And inshallah, I'm hoping that you all will engage.